Thanks for joining us this evening. I'm joining you guys from the Memorial City office on the 13th floor, and tonight we are going to be talking a little about PCOS and related fertility issues and health issues. And so, hopefully this is a pretty engaging talk. It's actually a variation of a talk that I gave to medical students back in 2008. So I actually ended up reusing some of my old slides, which was a trip down memory lane for me. But here we go. Okay, so PCOS, polycystic ovary syndrome is what it stands for. And the diagram on the side of the screen is really not meant for study. It's just to kind of describe how complicated of a condition it is. And this is sort of a representative example of what the basic science and laboratory side of medicine understands. But then on the other side, there's the clinical side, or what patients experience. So maybe this is what many of you patients are struggling with, but basically it can be described as a group of symptoms that happen together. Patients usually have irregular cycles, but that's not necessarily true for everybody. There's also a tendency towards symptoms of what people call high androgen levels or male type hormones. People refer to these as like testosterone, which is a type of androgen. But whenever I say the word androgen in this talk, it's really referencing male type hormones. It is a super common endocrine disorder. I would say conservative estimates have it at about 1 in 10, but there are some studies and examples of this maybe being as high as 20% of the population. Typically, patients with this issue have problems that start off in the adolescent age group, but then can progress and change into some different issues in late adulthood. And the cause is not well understood. We don't really know if it's a genetic thing or if it always runs in families or if it's unique to the individual, but patients can definitely have different findings. So as for an overview, instead of going through like sections, intro, body, and the conclusion, I think these are the questions that we'll be addressing, and these are hopefully some questions that you'll have the answer to by the end of the night. We're going to talk about what is PCOS, how does a doctor diagnose PCOS, what other things are important to think about when it comes to a diagnosis of PCOS, how to stay healthy during PCOS, and is there any good news? Because I think so often there's just so much information about PCOS that it can get very frustrating, but believe it or not, there are some positive sides to this. How do we treat PCOS? Why is it so hard for a patient with PCOS to get pregnant? Are there any supplements to take? And what does fertility treatment look like for a PCOS patient? All right, so how to diagnose PCOS? This slide is actually incredibly straightforward. But really hiding behind this slide is an incredible level of nuance. So we find in our practice that for patients who sometimes have a diagnosis of PCOS that's real and it's true, they may have seen many doctors before they finally come up with a final conclusion. And some patients who walk in the door saying, they've been diagnosed with PCOS their whole life actually turn out not to have it. But anyway, it really can be simplified to this slide. And basically, in order to diagnose the syndrome, patients need 2 out of the 3 numbers on the slide. Number 1, a patient would need to have irregular menstrual cycles, and in the literature and in our notes, we often type that up as abnormal uterine bleeding. Patients also need to have evidence of high male type hormones or androgen levels, and this could be manifested as either acne, and typically we're not talking about just simple frustrating acne. It typically is that cystic kind, hair growth, which can be quantified, but it's a little bit subjective, or elevated testosterone levels. And then the third thing would be ultrasounds, ovaries on the ultrasound that look a little different. So ovaries that are either too big or have too many of these resting follicles. If I show my mouse here, hopefully you guys can see it, but these little black circles here, if that number crosses a certain threshold, then that would qualify as abnormal ovaries. So as you can tell from this slide, patients with PCOS can look drastically different. They could have, for example, numbers 1 and 2, or numbers 2 and 3, or numbers 1 and 3, or sometimes all 3. And what is sometimes misunderstood is that some patients who only have number 3 are characterized as PCOS when in fact they don't meet criteria because they don't have another thing to back that up. It is, as I've alluded to, an incredibly complex diagnosis. It is so tricky, even that different ethnic groups have different presentations. And so this is a generality chart, but amongst Asians, there's typically a higher risk of irregular cycles, but they generally have fewer of the androgenic side effects like the skin and the acne and the hair growth issues. What's also a little unusual is that patients of Asian heritage also tend to have like a slightly blunted response to certain fertility treatments, and that has been observed in many different centers around the country and around the world. South Asians typically have a higher incidence when diagnosed with PCOS of metabolic diseases and irregular cycles. African American and Hispanics will trend toward a little bit more metabolic disorders and obesity, as well as heart disease, as well as a higher incidence of the androgenic effects. And then the Middle Eastern and Mediterranean populations tend to have more metabolic diseases, maybe obesity, heart disease, and then a higher risk of acne and hair growth. So you can see that, you know, just looking at somebody from the outside and studying what we call in medicine the phenotype doesn't really clue us in on what's going on. Okay, so PCOS, what's in a name? What's really, really tricky and honestly a little frustrating for patients and for docs is that, you know, with PCOS, these are actually not cysts. It is a true statement to say that patients with PCOS generally do not have cysts in their ovaries. This condition was described first by a couple of, you know, now deceased but famous docs almost 90, 100 years ago. And they basically collected a bunch of women who had similar symptoms. And upon studying their ovaries, they found that all their ovaries looked a little cystic. And so the name stuck. But the cysts are actually resting eggs in the body. They're resting in the ovary. So really, these are extra eggs that were misinterpreted and misread as cysts back in the day. What's also a little frustrating is that PCOS draws your attention to the ovaries as being the center point of condition, but honestly, the ovaries are probably not even the main actor in this condition. It truly can be interpreted as almost like a biochemical intrinsic change in the body's biochemistry. And even though PCOS is most obviously manifested in the ovaries, you know, you do someone's ovarian scan, and that could be the most obviously different thing between person to person, the majority of its effects actually start, you know, maybe in the biochemistry, but sort of transmit all the way to other parts of the body, metabolically, you know, we'll see in other slides, dermatologically, even psychiatrically. And so, you know, this is my tongue-in-cheek slide here, but maybe a better name for the syndrome would be, you know, a too many egg, irregular ovulation, extra male hormone with other body parts affected syndrome. That name would never catch on, but it is much more descriptive and helpful of a condition name than polycystic ovary syndrome. Okay, so PCOS related and associated issues. Patients with PCOS, they are often sort of told earlier in life that they have it, but they often don't present, at least to our clinic, until it's a fertility issue because as bullet point number 1 shows, it can lead to unpredictable ovulation. The unpredictable ovulation will throw off the cycle and it makes it harder to get pregnant. But with that condition, there can be lots of other things. So for number 2, typically we're going to do a blood check for patients who are suspecting this condition in, and we'll see something called a high, or typically a high elevated AMH level, which is suggestive of a higher than expected egg count. There's also a blood test called the LH, or the luteinizing hormone level, which tends to be much higher than expected. And this is tricky because that LH level is also the hormone that spikes right before ovulation. And so when women and couples purchase those ovulation predictor kits that you can find at the drugstore, and sometimes they can be very costly, the LH in a non-PCOS patient should spike and then, you know, hint at future ovulation within the next 12 to 36 hours. But in PCOS patients, that level can be persistently high and can trigger some false positives. And so if you read the fine print in those predictor kits, it'll actually say not recommended for use with patients with PCOS. There is unfortunately an increased risk of metabolic issues and weight issues, as well as heart disease. Prediabetes and future diabetes is definitely a thing. There's even a higher incidence of depression and anxiety, skincare and acne issues. But I would propose to the audience members tonight that number 7, or the future risk of endometrial or uterine cancer, would actually be probably the most important thing on this slide, because this is literally a life-altering diagnosis. We are dealing with a population of patients that typically will not present with this condition yet, but it's important because while all the other stuff is central to our life now, this isn't really on most people's radar, but it can actually be prevented pretty effectively, as we can see in some slides. Okay, so we're going to digress a little bit and just talk about the health of the uterus and how to stay healthy, because this is actually a very big deal when it comes to patients who have irregular cycles in the umbrella of PCOS. So again, not everyone has irregular cycles, but these few slides really pertain to those who have irregular cycles. So as for the health of the uterus, basically, in order to go through these next slides, we have to talk about how the uterus works. So the rules of the uterus, so to speak. So the rules of the uterus are that number 1, the uterus needs a routine. This is not an organ that you can sort of just ignore and disregard what it's doing. Number 2, the uterus actually does what it's told. So it doesn't really usually have a mind of its own. The heart does what it wants, the ovaries do what it wants. Just lost my visual slide here. Hopefully you guys can see me. So the uterus does what it's told, and what it's told are the 2 main signals that come from the ovaries. And the ovaries, as well as other parts of the body, but primarily the ovaries, they produce 2 main hormones. One hormone is called estrogen, and estrogen thickens the lining in the uterus. And you can think of this as preparing the uterus for a potential pregnancy. And then there's another hormone called progesterone, which basically after it shows and after it disappears, it causes the lining to shed. Okay, so estrogen thickens, progesterone sheds. And this might sound kind of odd and kind of silly and maybe a little tacky, but the best way to describe this that I use for my patients would actually be something like a grassy lawn. So basically, if you think of grass, you need water to keep that thing healthy, and that would maybe represent the estrogen. And then every month you would need something, a lawn service or a lawnmower to clean off the grass in order to keep it healthy. And if you don't do that, things start growing that are not supposed to be there. We've all driven by these houses where maybe the grass is a little too tall and you got some weeds, and the same thing can literally happen inside the uterus as well. And so basically, if someone is struggling with PCOS, because they're not ovulating, there is very little or frequently no regular exposure to progesterone, because progesterone is the main hormone that is produced after ovulation has happened. Progesterone literally is made by this tiny little spot in the ovary where the egg popped out. So it produces progesterone for about a 2-week burst, it disappears, and then that serves as like the uterine housekeeper. So the way to keep your uterus healthy is actually to kind of hack the system and understand that these rules apply. You can actually trick the uterus into thinking that there has been an ovulation. So in fact, progesterone was discovered decades ago, 1950s, 1960s, that kind of time frame, and they figured out how to make it. And if you feed someone, or if you administer progesterone to a patient who has irregular cycles, who's got a lining that's thickened and perhaps a little overgrown, the period will happen. And many of you may have taken something like, Provera or something like that. But these days, natural progesterone is not the most common path. There's a synthetic progesterone category called a progestin, and progestins are just basically more effective versions of a natural progesterone that your body makes. And progestins are everywhere. They are the main ingredient in birth control pills. They're the main ingredient in an intrauterine device. Some people have taken something called Depo-Provera injections, vaginal rings, birth control patches. Basically, there's so many different ways of delivering progestins or progesterones. And so here's kind of a visual representation for the visual learners of what's going on. So if you think of what a typical menstrual cycle will look like, if this is a 28-day cycle and ovulation happens in the middle, typically what happens is that progesterone will spike in the second half of the menstrual cycle, and that is again due to where the egg came from. And then superimposed on this chart would be the uterine lining. And the uterine lining basically sheds in the first couple days of the cycle. And then as it builds, it's actually the progesterone surge that induces the next month's period. So the whole system just kind of stacks on top of each other. In patients with PCOS who have irregular cycles, what's happening is that the progesterone levels do not regularly rise and fall. They're just kind of stuck low all the time because, again, cycles can be very irregular, and there's some women who truly do not ovulate at all. And then the lining just gets thick, and it gets thick to the point where it's just so thick, something's got to give, and then that may represent as spillover bleeding. Sometimes that can be a small cycle, and some other women it could represent like 30 or 40 continuous days of bleeding. There are even patients that show up in the emergency room because they've just bled so much that they start to feel faint and can even pass out. Okay, so moral of the story for those few slides is that you can and you should protect your uterus from future precancerous changes by talking to your OB doctor, or at least talking to a fertility doc if you started this conversation. And care of your uterus extends far beyond the conversations that we have in a fertility clinic. So basically with PCOS, there's a spectrum of understanding. In the younger age groups, people are struggling with irregular cycles, acne and hair growth, anxiety, depression. And then sort of the middle age group, that's kind of where we're at, in the 20s and the 30s, and sometimes in the early 40s, that has changed into maybe some infertility and maybe some early diabetes and heart changes and uterine changes. And then basically as we move forward in life, some of those changes persist, but that can morph into diabetes, heart disease, and true uterine cancer. I think the point of this conversation now is that we are in an age group where prevention is key, and the goal is to basically negate or cancel or try to prevent a lot of these major issues from happening before they really get too bad. Okay, so what's the good news? All right, I've just beat up everybody about the diagnosis of PCOS, but believe it or not, PCOS can actually be almost a bit of a superpower because there's so much control that a patient has with their health that a lot of these variables are modifiable. What's interesting about PCOS is that when we do ultrasounds, when we do blood tests, we will usually see that there are more eggs than expected. If we compare people with and without PCOS, I'm not much of a gambler, but if I was, patients with PCOS are likely to have more eggs almost every time. And so what that means is that when it comes to fertility treatments, patients typically respond really well, sometimes too well, but really well, and that really helps with long-term prognosis. The other thing about PCOS is that typically the worst symptoms are in the teens, 20s, and 30s. Some patients actually can even transition out of their diagnosis. And what I mean out of their diagnosis, they literally will no longer meet the 2 out of the 3 criteria. And while it's not really a cure, a lot of their symptoms as the androgen loads decrease will get better. Okay. So general management of PCOS, unfortunately, unlike this slide, there is no magic pill. There's not one magic pill or bullet to take care of the skin and the hair and the fertility and all of this stuff at one time. But one of the main tenets of PCOS is to really ask yourself the question, am I trying to get pregnant right now? And if the answer is no, right, if the answer is no, then patients who have irregular cycles really need to stay on top of their uterine health. The answer should really not be maybe. And I know for many people the answer is maybe, and they'll just kind of try if they want. But because of how the uterus works and how unexpected, unpredictable the ovulation patterns can be, it's not really something that people should sort of, I guess what I'm saying is that patients with PCOS should be very deliberate in their efforts to either conceive or protect their uterus. So if the answer is no, talk to your doctor about staying on top of your uterine health. If the answer is yes, then at least start a conversation with your OB doctor. If not, just go directly to a fertility specialist, because we're not really too keen on the idea of waiting for a spontaneous ovulation in someone who does not really ovulate. It's just, I think it's just very stressful and it's very unpredictable, and it's just overall not a great thing. In terms of the hair and acne, there are lots of medical, there's pills and procedures, electrolysis, cosmetic things that can be done. That's sort of on a case-by-case issue, case-by-case basis. With metabolic diseases, so this is a conversation with either your primary OB doc or your family primary care doctor. But there needs to be some very routine and regular screening. Healthy exercise, healthy diet and lifestyle is imperative. Weight control is important, and there is a good amount of research that patients with PCOS, they truly metabolize carbohydrates differently. Carbohydrates are, they're being villainized right now. There's a lot of research ongoing about how, the food industry over the last few decades has really shifted the public opinion in their favor to kind of increase grain intake and carbohydrate intake. But overall, that's probably not been a good thing for long-term health, but especially in PCOS patients, there needs to be at least education and careful consideration about overall carbohydrate intake. Psychiatric issues can certainly be important to deal with. So a good social support network, group support, therapy, medications if necessary, but there is definitely an increased vulnerability for patients with PCOS to struggle with mental health. And then infertility, which we'll talk about here in a little bit. So infertility treatments, PCOS treatments with regard to infertility are multifactorial. And one thing that I think fertility clinics probably don't emphasize enough is that there is good evidence to suggest that even 5% body weight loss can tip some patients into spontaneous ovulation. Now, this isn't true for everybody. I have seen some of our patients, some of my personal patients go through like remarkable changes. I mean, I remember one or two that lost over 100 pounds, and they just, unfortunately, their bodies just kind of got stuck in that no ovulation cycle. But there is definite benefit, and I would say about 30 to 40% of people with even 5 to 10% weight loss will tip over into spontaneous ovulation. And then if that's not going to work, many times patients have come to see us already and they're hoping for something a little bit more effective. There are pills, there are even some injections that are possible. Success rates with these more conservative treatments can range anywhere from 5% to maybe as high as 25% per month. But, if we're just doing simple ovulation and putting sperm inside the uterus, we really risk the possibility of, first of all, frustrating treatment because the success rates are on the lower side of what we would hope for as a society, or we could push buttons on a phone and get dinner ordered to us. It's just a very low and slow way of achieving pregnancies for many people. The other concern is actually multiple births. Patients with PCOS, their ovaries tend to be a little bit more sensitive to medicines and may actually even be at risk for a higher incidence of multiple births compared to other people. Not by much, but maybe a little bit more. And so the real and medical consequences to that can be significant. And then, of course, there's IVF. This is not the only treatment for most couples, but is oftentimes the most advantageous. Patients with PCOS tend to respond literally better than other people, and this is said in a loving way. If I could fill my own clinic with a bunch of patients with PCOS, who are otherwise healthy and just had irregular cycles, and I think most of my partners would agree to this, our lives would probably be a lot easier, because unfortunately there are just a lot of patients who are struggling hard with low sperm counts and low egg counts, and sometimes we feel like we're just banging our head on a wall because we try the same thing in different ways and it doesn't work, whereas the patient with PCOS, we try once and we usually get this overwhelmed, exaggerated, really awesome response. And then in terms of supplements, there's a whole world of supplements out there. There's literally 100 supplements that you could take if you want to go down that very slippery slope. But there is some evidence to say that there's this category of compounds called inositols, and they've been suggested as helpful, and they're thought to actually change the way some of the receptors in the body signal to each other in this different PCOS environment. And typically it's supposed to be a ratio of something called 40-to-1 ratio between something called myo-inositol and D-chiroinositol. Those are just a bunch of words that are not important, but if you literally memorize the 40-to-1, or if you want to just look on Amazon or whatever, eBay, for something called ovasitol, most of these inositol supplements have already been designed where the doses of the one versus the other are pre-mixed at a 40-to-1 ratio. Okay, so here's a little bit more in-depth conversation about PCOS patients and specifically with IVF, because obviously as a fertility clinic, we do a lot of IVF, and I think the moral of the story for our clinic is that IVF may not be the only choice for most patients. In fact, most people, they've got many, many, many options, but there are some patients who just have such good and favorably predicted outcomes for IVF that if there were ever to be a patient who would benefit from IVF, it would probably be more likely a PCOS patient. So what I mean by that is that PCOS patients are commonly referred to as high responders. And so back to that first slide where we had the ultrasound full of, those little dots and the black circles, most people with PCOS just have more black circles. And you can really interpret that as like a higher ovarian horsepower. So when people are actually pushing the ovaries with medicines, patients with PCOS make more eggs. They typically need lower doses of IVF medicine, which can be a huge cost savings as well. What's also very amazing is that patients who do IVF, they often can get away with one cycle. And so, for example, if I told you that the average person doing IVF gets 8 to 12 eggs, that's great. That's actually wonderful for many people. If the average, egg to embryo conversion is about 3 to 1, so maybe that person with 10 eggs gets about 3 embryos, it is very common for patients with PCOS, in contrast, to get 15 or 20 or even 30 or believe it not even 40 eggs. And so if we end up with one of these patients who maybe didn't realize it, but they're tested and we realize, hey, you might be a super high responder with 20, 30 eggs, they may end up being able to achieve and mature 4, 5, 10 embryos. And all those embryos can actually hang out in our lab, and they can actually help couples achieve multiple kids over many years with only one round of IVF, which is very different from some other patients who may have to do multiple rounds of IVF to even get 1 or 2 embryo transfers out of it. So again, PCOS patients, they definitely have an advantage there. And, as long as patients with PCOS are typically in that, early, mid, even late 30s age groups, they typically have higher than expected rates of success. So not only do they get more eggs or get more embryos, but age for age, a 40-year-old with PCOS with extra eggs will absolutely have better rates than somebody who has fewer eggs. So hopefully that was informative. This conversation can be taken in literally any direction. There are, scientists around the world far more accomplished and smarter than, I will ever be, who have dedicated their lives to the study of PCOS. And some of them work in a lab, culturing cells. Some of them work clinically doing, large trials, but really, I am, and hopefully patients are the beneficiary of all this information. But the summary of tonight is that PCOS is a diagnosis of menstrual irregularity and an androgen excess. For those who have irregular cycles, the prevention of endometrial or uterine cancer is important and is a necessary life adjustment for many people. PCOS is associated with many other conditions, most importantly, the metabolic issues of obesity and diabetes and heart disease, which a lot of them are related, and these should be actively addressed and prevented. And then patients with PCOS often present with infertility. We are sometimes the first line caretakers of patients with PCOS. I often meet patients with PCOS who've had it their entire lives, and through just sort of life circumstance, we're the first ones talking to them about how to take care of themselves. And so many of these patients do require medical support to conceive, but the good news is that fertility treatments for PCOS patients can be highly effective.